So good evening, everyone, and welcome to this evening's webinar on approaches to stricturing biliary disease in 2025. I'm Louisa Vine, and I'm one of your chairs for this evening, and I'm the BASL Education Lead. And my co-chair is Dr. Deepak Joshi, who's the BASL Secretary. It's my great pleasure to be joined by our two experts this evening, Dr. George Webster and Dr. Emma Culver. Before we get started, though, I'd like to thank our sponsors, Cook Medical. They have no influence or input into the programme, agenda or content of this meeting. So I think there'll be lots of opportunities at the end to ask questions, so please do put any questions into the chat. And without any further ado, I think I'll hand over to Dr. Webster and Dr. Culver to get started. Thank you.
Great. Thanks ever so much, Louisa, and delighted to be with you to get stuck into biliary strictures. I'm older than most of the people on the chat, and when I started off, the question was simply, is it benign? Is it malignant? Is it PSC? And that was basically the full extent to which we thought about biliary strictures. Things have changed a great deal, and we're going to start off by a very brief case history of a 68-year-old man who presented with a couple of weeks' history of itch, jaundice, pale stools, painless. Bit of a background history that a few years ago he had really nasty COVID-19, ended up on ITU and on a ventilator for several weeks, but got over that. And he's also got some hypothyroidism. Blood tests that we have, well, you can see them. He's got a mixed but particularly cholestatic picture of liver derangement. His CA 19.9 is elevated at 256, top of the normal range being about 30. And I'm showing you a single picture of his MRCP. Emma may wish to comment a little on that, but essentially, you know, complex biliary stricturing up at the liver hilum. And so I'm going to hand over to Emma to talk about initial approach and differential diagnosis, and then back to me to talk about endoscopic approaches. Thank you. So I hope you can share your screen, Emma.
So I'm going to ask if Kim can possibly share the screen. I can't see the slides at the moment, but hopefully they will come to us very shortly. Can you see slides, George?
No, I can't. But what I can do is there's no particular order to this presentation, and while your slides are being sorted out, I could do my bit if you like.
Yeah, you can talk about the endoscopic side of things, and I will see what we can do about the slides on my side. Thanks.
Says. Okay, good. Oh, I do have a. Sorry about this. It's rather strange. I'm trying to advance my slides. Okay, bit of a whistle-stop tour. What I want to ask the question of is, what can endoscopy offer for the assessment of this patient with biliary stricturing or cholangiopathy? And it can certainly offer diagnostics. It can offer cholangiography, which is ERCP, broadly speaking, lesion visualization, tissue sampling. We're going to talk a bit about that. And then it can offer intervention, and we'll talk a bit about that. The other thing it can offer is risk. And I think that we really shouldn't get stuck into talking about endoscopy and ERCP here without being really aware of risk. So the MRCP you saw, we'll go on to what the possible causes of that are, but this is a complex biliary stricture, and we need to be absolutely sure that we're aware that when we do an index ERCP on this patient, we are exposing them to risk. Clearly, the risk of ERCP-related complications such as pancreatitis, but also that first ERCP is very likely to colonize bacterium into the biliary tree, which in the setting of a cholangiopathy may represent real problems and difficulties for the future. So we need to start absolutely outset to think, what is the potential gain from doing an ERCP in any patient with a biliary stricture? Emma's going to talk a little bit about differential diagnosis, but I would just make the point that when we do an ERCP, we get pretty pictures like you can see here, but do they help with the diagnosis? So we, some years ago, did a study asking experts around the world to tell us what they were looking at. Were they looking at PSC? Were they looking at cholangiocarcinoma in the setting of PSC? Or were they looking at IgG4 sclerosing cholangitis? And you can have a little look to see what you might say yourself. These are the answers, but I can tell you the conclusion was that we're all terrible at making a diagnosis based on an ERCP. So if you think you're going to drive forward the diagnosis based on a cholangiogram, above and beyond what you've seen on an MRCP, you are almost always not going to do that. Emma's going to show some slides that, just a few years ago, we were saying, well, the differential of PSC is simply, is IgG4 sclerosing cholangitis. We're all pretty comfortable with that now. But another couple of new kids on the block are checkpoint inhibitor cholangiopathy, patients on drugs like pembrolizumab, ipilimumab, for a range of malignancies, particularly things like malignant melanoma. The pattern of pancreaticobiliary disease in those patients can, in my judgment, absolutely mimic that of IgG4 disease, because there's also pancreatic involvement. And a newish disease that we're seeing increasingly now, which is ketamine cholangiopathy, really nasty disease that often is seen in conjunction with the terrible bladder disease, but not necessarily so. So cholangiography is not going to get you very far. What about cholangioscopy? So visualization, it's the sexy new tool that we've had for the last 10 or 15 years. What does it allow us to do? Well, make a visual diagnosis, and it can be very useful for identifying stones that haven't been previously seen, and identifying the extent of mucosal change. Now, there have been various scoring systems and classifications. If you look top right, I can tell you that that is a friable papilliform tumor. That's easy. Bottom right, and we'll come on to this, what is that? There's abnormal blood vessels, there's a bit of nodularity. Now, some of the scoring systems and some of the results would say, oh, that's cancer. Well, I'm really, really not so convinced about this. And this is a study that we did through the European Cholangioscopy Group. It was published a couple of years ago now. And in that, we gave experts high-quality videos of cholangioscopy, videos of strictures, and we said straightforward questions: is this cancer or isn't it? And initially we said we're not going to give you any information, which was the blinded group, and then we gave lots of information, and that was the unblinded group. And I think you'd probably agree that we were rubbish at making a visual diagnosis. And if you then look at the inter-observer agreement, it was terrible. And so my conclusion of this And this has got nothing to do with the quality of cholangioscopic vision. It's got better and better, but it has not allowed us to dramatically improve the visual diagnosis. And then, just as an example, what do we think about this patient? You can see top right, they've got a cholangiopathy. Is this cancer? There's a bit of nodularity, definitely abnormal blood vessels there. We took targeted biopsies, and I'll come on to this, and they showed, and his future history showed, IgG4 related disease. Now, if you were just making a visual diagnosis, you would diagnose cancer in this patient, and they'd go on to perhaps have palliative stenting, perhaps have major surgery, which was not necessary. So if we're talking about biliary strictures, tissue is almost always the issue. Now, I'm not going to go into this in detail, but if we're talking about ERCP or endobiliary sampling, we have three choices: biliary cytology, endobiliary biopsies, or cholangioscopic biopsies. We know that biliary cytology, we should always be doing it when we're faced with a stricture, but the sensitivity is really bad, 30 to 50%. That is not good enough. And we've all been in the multidisciplinary meeting where the patient's had an ERCP, they've had biliary cytology, the cytology is negative. What do we do next? And what I would argue is that we have to be pushing more strongly. Now, some of this data is a bit historical, and there is no doubt that there is single center data or even multi-center retrospective data on tissue diagnosis, which is too good to be true in clinical practice. But what I would take from these various studies is that we need to be using more than one modality to make a tissue diagnosis. So the days in which it is acceptable just to wave a cytology brush across a stricture, they are gone, in my opinion. Certainly in our unit at UCL, we're increasingly pushing to try and do everything at that index ERCP. Yes, biliary cytology, usually cholangioscopic biopsies, sometimes fluoroscopic biopsies, which you need to be careful about, but can give even bigger samples. And particularly if there is a mass associated with a lesion, then consideration of EUS guided biopsies. So it's much better to have done all of this at the index procedure so that one can then go to the multidisciplinary meeting to say, look, we've done all that we can. Now you've got to think about how you take this forward, rather than in a laborious, time-consuming way, do multiple procedures, doing an extra test at each procedure. That really delays care for these patients. And so one of my take-homes is more than one modality. PSC, for hepatologists amongst us is, oh my goodness, it's such a difficult disease. And the dominant stricture in PSC is a real challenge. And there's a couple of studies. We were involved in the lower study. Essentially, even if you take visually directed sampling, as we're seeing here, and this horrible stricture that for all the world you would say this is cancer, and it wasn't, we're not good. We are not good at either making a visual diagnosis or a pathological diagnosis in PSC. So I think it's a real unmet need. Let's talk a bit about stents. I suppose, again, my take-home point is choose carefully. Now, one of the sponsor of the webinar this evening is Cook, who make the first 4 stents, and that's not, I haven't put that list up here because Cook are sponsoring. You know, they happen to be our go-to stent manufacturer in our unit, but we need to understand what stent we're using and why we're using it. I would say at the outset that it is never a crime to use a plastic stent. A straight plastic stent across a stricture, definitely before you know the etiology of that stricture, is never a mistake. Pigtail stents, bear in mind that pigtail stents drain around the stent, not through it. And so we never put a pigtail stent on a single pigtail stent through a stricture because it will block. Now, if we're talking about SEMS, self-expandable metal stents, they are a fantastic option in the right patient. Now, if you have a patient with an extrahepatic biliary stricture, even if you don't know the diagnosis, then a fully covered mesh metal biliary stent is a fantastic option. You can take it out. It does a great job. It reduces jaundice more quickly, more effectively than any form of plastic stent. But you cannot put it across the liver hilum. Okay, an uncovered metal stent can be put across the liver hilum, but never, ever if you do not have a definitive pathological diagnosis. Okay, so moving across this list, the intraductal fully covered SEMS is something that I know Joshi may wish to chat about. Real role in anastomotic strictures, particularly post-transplant strictures, because this sits across, for example, a mid-bile duct stricture, but has a very low rate of migration, which can be a problem, particularly for post-surgical strictures, for example, post-transplantation. And then finally, biodegradable stents. I think there's an emerging use of these, and maybe we'll chat about those a bit. They may have a role, particularly in selective indications, perhaps post-biliary biliary leaks, and maybe in the setting of PSC after stricture management. But others on the panel may have an opinion about that. And I've shown this before because this is a crime that is unforgivable. So this is a patient who was diagnosed several years previously with what was, everybody said this is going to be cancer. And so an uncovered metal stent was put in and it never was cancer. And then years later, this patient is now obstructing his bile duct due to ingrowth. There is no prospect whatever of removing this stent. And in our transplant centers, we've had a number of patients now who have ended up needing transplantation because everybody thought it was cancer and it was IgG4 disease or lymphoma or some other indication. That is unforgivable. So my mistakes not to make, and I'm nearly coming to the end, stenting without prior imaging review, especially hilar strictures. All of these patients need to go through an MDM. They need to be discussed in detail. I've made the point, never put an uncovered SEMS in without malignancy. Also, partially covered stents, put them in the bin. Put them in the bin, or at least get your wonderful cook or other rep to swap them with lovely, fully covered metal stents because they are a nothing. Okay, you cannot put them in a patient who doesn't have malignancy because the proximal uncovered bit will get them stuck and they have no advantage over a fully covered stent. So forget them. Not time to talk about bilateral hilar stenting. Metal stents are great in that indication, but they have to be good. They have to be done properly. As I say, if you put in plastic stents across the liver hilum in cancer and you get the stenting wrong, it's no problem. You can go and do it again, or you can go percutaneously or whatever. If you put uncovered stents in and the goal is to put bilateral stents, you've got to get them right. Finally, do not lose your patients to follow-up. A common indication, for example, for a fully covered SEMS in benign disease is chronic pancreatitis. Many of those patients, for example, might be patients with alcoholic pancreatitis with perhaps slightly chaotic lives. If you lose that patient to follow-up and they haven't come back within 12 months, you can find that stent is stuck, and then you're in a real big problem. Finally, balloon dilatation. Again, we do use that for benign strictures, very much for PSC strictures. We only ever use balloon dilatation for malignant strictures if we cannot get a stent through without doing that. Really important seminal study led by Cyril Ponson from Amsterdam a few years ago now, the DIL stent 2, comparing balloon dilatation versus balloon dilatation and short-term stenting. Now that study, nicely done, multi-international study, was stopped early because of a significantly increased rate of complications in the stenting group with no benefit. And so the considered wisdom is that there is no role for stenting of PSC strictures, and I hope that the faculty might have a bit of discussion about that at the end. If you want to know more about biliary strictures and cholangioscopy, etc., then please join us for our free webinar or free 2-day symposium in a few weeks. You can register online. It'd be great to see you. We can either discuss these points now or at the end of Emma's discussion. Just some things for us to have a little think about. Thanks.
Thank you, George. Great overview in quite a short amount of time. We've got a couple of questions.
Yep.
So one of them is, do you ever consider EUS FNB of a dominant high-grade stricture in PSC in the absence of a mass? Maybe that can increase the yield. What's the approach at UCLH?
Yeah, I suppose a few things to say. In the, if the bile duct wall is very thickened, even in the absence of a mass, you can get a diagnosis from EUS. The more proximal the stricture, the more challenging EUS and the lower the yield. And in fact, Joshi, you might have input about this. There is soon to be, or maybe it's already started, there's soon to be a national program, I understand, of transplanting patients with PSC and cholangiocarcinoma. And my understanding is that transduodenal EUS biopsy will preclude that. I certainly know in the States and elsewhere that there's a lot of concern that if you are not removing the tissue along the track of an EUS biopsy, then they're very concerned about that, perhaps overly concerned. But what's your view, Josh?
Yeah, no, I think the worry potentially is of peritoneal seeding. So I think, with a standard PSC high-grade stricture where there's concern on imaging of potential underlying malignancy, we'd go for a ERC approach with cholangioscopy, brushings, throwing multiple modalities at it to try and make a diagnosis. And then, obviously the pre-operative imaging helps a lot with PET scanning as well. So it is making sure that these patients are discussed. And I think that's the key point, that these patients are discussed before, because in theory you can seed the tumor and then make them potentially untransplantable, or they stop being a surgical candidate. So I think that's where the discussion is.
So Josh, so at King's, would you explicitly avoid EUS biopsy and PSC in a patient who might be a candidate for transplantation or even might be a candidate for surgical resection?
Yeah, I think that's the discussion that needs to be had before. You know, you need to see where the lesion may be. You know, periductal thickening can be very sort of mild, and your diagnostic yield of that can be quite variable. So you do need to be careful. Obviously, if there's lymph nodes, you can target lymph nodes. Again, if there's concern, especially if they had PET scanning, which they're lighting up as well. But obviously, it can't tell you whether it's infection if they've had an episode of cholangitis, or it is true malignancy as well. So it's about having that thorough discussion about the patient, because you don't want to disadvantage them. And yet at the same time, you want to make sure that you're not missing an underlying cholangiocarcinoma, which obviously may come back quite aggressively post-transplant. So that can be quite difficult, that discussion. There's lots of questions. I think what we're going to do is let's move on to Emma's talk, and then maybe we can come back to some of these. Now, Emma, I'm going to try and share your slides. Bear with me.
If you want to address the questions, Joshua, you can, because then I can just skip over the bits which cover them in my talk. I'm very happy to be flexible because I can whip through mine quite lovely. Well, thank you very much. And thank you very much to George stepping in, talking about endoscopic therapy before I talked a little bit about approach to stricturing biliary disease, but I think they will flow quite nicely even in the brilliant. So I thought we'd just start with a simple definition of a biliary stricture, just for everyone. And I know now we've talked quite a lot about biliary strictures, but kind of key thing that we're looking for is an abnormality or a narrowing within our ductal system within the liver. And I say that because when I get to talk a little bit more about imaging, and particularly some of the technical challenges of imaging, actually we notice that sometimes actually a true biliary stricture that we believe we see on imaging is not in fact a stricture that is in the liver, but is in fact some kind of artifact on the imaging itself. And this usually causes some kind of clinically or physiologically relevant obstruction to the bile flow. And in the early stages, many of the patients who have a biliary stricture we might detect on imaging may be completely asymptomatic. And in fact, the liver tests may not be obviously apparently cholestatic, or they may not be jaundice. So there's different presentations and modes of different presentations with regards to these strictures, both that can present with patients who have cholestatic symptoms and cholestatic liver tests, but also just with imaging features alone. And we generally divide these strictures into anatomical location, which you can see here, and that helps us to broadly think about the differentials that might be causing the underlying biliary abnormalities into intrahepatic, perihilar extrahepatic, and distal extrahepatic. Also, we do the same for things like cholangiocarcinoma. Next slide, please. And I think, as you know, George highlighted nicely, I think the key thing and the key challenge initially is to determine the difference between benign and malignant biliary strictures. And then we have these indeterminate strictures, which I saw one of the questions about here, which indeed require longitudinal workup and continuous sampling to really look to see whether or not you can find a definitive cause, and whether you think it could or could not be benign, and whether or not a steroid trial will be appropriate, which again, I'll talk about at a later time point. I think the basic principles for me very much going into the cancer MDT or even to the benign MDT is that in adult, biliary strictures are more likely to be malignant than they are to be benign, except when you've got a very well-defined scenario, which we'll talk about, and either an identifiable insult or a trigger, and particularly one that you might be able to reverse. And those patients who have rapidly onset or progressive obstructive jaundice, again, are much more likely to have a malignant stricture that you need to look into more definitively. Next slide. So general principles, just to say, there's different imaging modalities for strictures. Often you'll find that patients will get a CT looking for a mass before they get an MR looking at the intrahepatic and extrahepatic bile ducts, plus minus the pancreas. But obviously we've talked and touched briefly on the roles for EUS and ERCP, and also the roles for PET, both in malignant disease, but also in benign disease. I think we have some technical limitations when we assess our imaging, including the movement artifact that we can sometimes see, and also the reconstructions. And we do know that often biliary strictures are miscalled, particularly if you have indentation at the hepatic artery at the hilum. And so we often get a PSC with a hilar stricture that in fact is just a hepatic artery indent, or indeed flow artifacts within the bile ducts. And therefore, I think it's important sometimes to actually repeat your imaging and or go to a second radiologist to have a look at that imaging in order to be able to get a good idea if this is truly a stricture or if indeed it's an artifact of the imaging. And also sometimes there are different interpretations of what is ductal irregularity and or beading within the bile ducts. And repeat imaging sometimes with or without contrast can help us to be able to define that. It also depends on the technique you use, the T1, T2 weighting, and the use of contrast. And I guess the way that many radiologists, and I think many of us think about when we look at bile duct strictures, we want to look at these stenoses, look at any post-stenotic dilatations, look for any evidence of calculi that might be intraductal or elsewhere, and look at actually the homogeneity of the actual liver parenchyma, and particularly for hepatologists, that's really important, looking for any kind of liver dysmorphia and signs of portal hypertension. And that feeds into our thinking about our chronic biliary diseases or our secondary biliary cirrhosis, and also into some of the imaging related scores that we use for prognostication in things like primary sclerosing cholangitis. And also think about whether we can examine these pre and post contrast. And as I say, sequential imaging is really important there. So it's not just the stricture itself, but it's thinking about what might be mimicking the stricture, and we can start to think about what might be causing the stricture and what impact it might have from looking at these features. Next slide, please. And a lot of this comes down to multidisciplinary team discussion, and all of us will sit in both cancer and also benign HPB MDTs, where you have surgeons, different medical interested specialists, whether it's pancreatologists, hepatologists, gastroenterologists, and then also the involvement, obviously, of our radiological, histological ecology, and also oncologists. I think here, and I'm going to go into it in a moment, I think clinical history is actually really key when you're looking at these referrals. And that is not only with regards to the age of the patient, the underlying demographic of the patient, but also previous drug history, other autoimmune factors and insults, which we'll talk about when we think about secondary sclerosing cholangitis. We think we need to know about the role of tumor markers, and while CA19-9 can be elevated in the context of jaundice and any kind of obstructive episode, obviously the higher it is in many instances, the more likely it is to be malignant. And we can talk a little bit about its sensitivity and specificity for certain conditions. But I think in a lot of these MDTs, we also have to think about our immune markers, and in particular the role of serum IgG4, which we know is not specific for IgG4 related sclerosing cholangitis or cholangiopathy, but we do know that it's actually got quite a high specificity at much higher levels, so 4 to 5 times the upper limit of normal, whilst it can be minimally elevated in malignant disease. And therefore it does have a role, particularly in those patients who may have pancreatic involvement or have any of the typical cholangiographic pictures, which I'll show you a little later. And lastly, we need to think about the role of histology in all of these cases. And George has nicely highlighted the role of EUS and also ERCP and biopsies in that context. Next slide, please. So what kind of symptoms do we often ask for our patients, or do we think about? Well, many of our patients who will have biliary disease will actually have jaundice. And if they don't have jaundice, they might have cholestatic pruritus, which is particularly often worse at night and is often on the palms and soles of the feet. They might have abdominal pain, particularly right upper quadrant biliary type pain. They may be excessively fatigued, which is the result of the cholestatic process itself, whether it is due to an underlying autoimmune condition or just its chronic cholestasis. They also may lose their appetite and also have weight loss, partly due to fat-soluble vitamin deficiency that can occur in the context of cholestasis and or in the context of pancreatic disease, which may occur alongside it. Next slide, please. So whenever we have a patient who's got cholestatic liver function, as you'll probably know from the EASL guidelines and pretty much mimicked in the American guidelines, we go through this kind of simple pathway to diagnosis. And that is taking a full history and examination. Often patients will have an abdominal ultrasound first to look for evidence of stones and also any evidence of malignancy in the first instance. They will have some serological testing to exclude simple things like PBC, and then they will go on to have extended imaging, the MRCPs, the EUSs, both looking for stones and different causes of cholangiopathy. And then in the absence of being able to gain evidence from there, we may go on to have a liver biopsy and or genetic tests, which again, I'm not intending to cover in great detail in this talk. Next slide, please. And lastly, when we think about management, I think key management priorities are thinking about whether we confirm or exclude malignancy, but also, as George has nicely talked about, thinking about restoring bile flow and how we do that. And that can be through dilatation, through stenting, and sometimes through reconstruction or surgery. And also in the context of benign disease, or in those instances where you have a post-operative problem, thinking about how we might be able to treat the underlying cause of the disease to potentially prevent progression. Next slide. So what kind of causes do I think of when I see imaging evidence of what would be stricturing biliary disease? Next slide. So sclerosing cholangiopathies, these are diseases where you get progressive narrowing and destruction of the bile ducts, usually due to inflammation and fibrosis. There's lots of different causes and therefore lots of different prognoses. And I think it's really important to make the difference between secondary and primary. And that's because pretty much everything that tends to come to the MDT, if it's not cancer, gets called primary sclerosing cholangitis. And we're lucky enough to run a PSC clinic where I work in Oxford. And yet we get a lot of secondary sclerosing cholangitis to that clinic because everything seems to be called primary unless there's an obvious discussion in the MDT initially about secondary insult. And so I think at the beginning, you have to think about demographic features, predisposing factors, any signs of progression of the disease, and then therefore the treatment options before you diagnose someone as having primary sclerosing cholangitis. Next slide, please. So this is just a list again from the European guidelines about all the different secondary sclerosing cholangitis causes. But I bet many of us, when we see patients in clinic, don't go through these kind of quite specifically, and also don't necessarily know some of the subtleties to look for on the biliary imaging or to think about with regards to progression of disease. And I think really broadly, these can be defined as those that are immune mediated, those that are due to infections, those that are due to ischemia, obviously those that are congenital, and then also those that are obstructive and also toxic. And I'm going to talk through some of them in my next few slides. Next slide, please. So ischemic cholangiopathy. We know that patients who have hepatic, or everybody actually who has hepatic parenchyma, will get supplied by both the hepatic artery and also the portal vein. But actually the bile ducts themselves only receive an arterial blood supply. So if you have an arterial defect, particularly to the bile duct wall, you can develop an ischemic insult. And that acute ischemic insult can then lead to biliary changes. Often we find that intrahepatic, but we can also find that at the bifurcation of the bile ducts and also in the mid-CBD. And we get, in the context of ischemia, you can have cast, you can have bile leakage, and a lot of this is all about a good medical history for those ischemic insults. And you can see on the two figures in front of you, first the anatomy of the bile ducts, and secondly below that, some of the ischemic strictures that has occurred as a result. Yeah, go ahead, Joshi. Thanks. This is a list of the causes of ischemia, and I'm not going to go into them greatly, but one thing I would say is to highlight there's lots of different systemic diseases that are associated with microvascular involvement. And so often I get referred a patient, for example, with systemic lupus, who happens to also have PSC, and you go back and you say, actually, they've got another systemic disease, or indeed someone who's got Behçet's, who in fact has a vasculitis, or someone who has sarcoidosis, who in fact has a sarcoid-related cholangiopathy. So I think, again, you have to think in the context of systemic disease, and there's a list of causes of ischemia here, which we should go through to think about ischemic insults that may have happened. Next slide, please. George has very briefly mentioned immune checkpoint cholangiopathy. I think this is actually a really important thing in the context today of the use of immune checkpoint inhibitors, particularly obviously for our cancers in the context of HCC as well as things like melanoma. Really, you get a very inflammatory reaction to the neoplastic tissue, and you also get specific immune insults, both to the bile ducts, but you can also get them to the pancreas as well. It's all CD8 mediated rather than CD4 mediated. And interestingly, both the imaging and also histology can look very much like IgG4 related cholangiopathy. And we've often had patients who've been referred but have the context of an immune checkpoint with an IgG4 questionable disease. And if you stain for IgG4 in the bile ducts, you tend to find none at all, even though the IgG4 can be elevated as it can be in many other inflammatory and infective diseases. Steroids don't tend to work so well in the context of in the context of immune checkpoint inhibitor cholangiopathy, although they have been tried variably in the literature, and they can improve the LFTs, but very rarely the stricturing. And I guess the key thing there is to stop the thing that causes the insult. Next slide, please. Ketamine cholangiopathy has received a lot of attention, particularly from Elon Musk, who has described a lot its use as an antidepressant, but it's also used as an anesthetic, particularly in the burns unit, and as you probably know, as a recreational drug, particularly in the US at the moment amongst clubbers. And we have quite a few ketamine-induced cholangiopathies that have been seen in and out of Oxford. We know that the ketamine itself can either be ingested, snorted, injected, and actually its half-life is around about 2.5 hours. and it's metabolized by the liver itself, and about 10% comes out of the bile and about 90% out of the urine, and it's all related to this CYP32A enzyme that is involved in the actual underlying cholestatic process. Next slide, please. So usually the key things that tell you about this in the history is the patients are young, usually around about sort of 25, but kind of varies. Obviously, you can use ketamine throughout your life. Most are male, and they often come with symptoms as well as a cholangiopathy, and that of pain, nausea, and vomiting, sometimes other motility orders, and they often have urinary symptoms, either pain and dysuria or also hematuria, because as you can see on the imaging in front of you, not only do you develop dilated bile ducts, but you can also develop retroperitoneal fibrosis and an ulcerative cystitis. We tend to get progression with intrahepatic and extrahepatic ductal involvement, and actually the key treatment is actually to stop the ketamine use. Next slide, please. These are some of the typical examples of what you can see with ketamine, including the extrahepatic ductal dilatation on the left-hand side, the more diffuse extrahepatic ductal dilatation in the middle, and then the intrahepatic ductal dilatation, or you could get some beading with some normal extrahepatic ducts. Next slide. So this kind of combination is really important, and this is just a slide on the right-hand side to show that actually, if you do stop the ketamine, there is a various response to that in a certainly timely fashion. So some patients completely normalize their LFTs, and over time you see their strictures involved, whereas some will continue to progress both their strictures and also the LFTs don't improve, depending entirely on the timing they've been taking ketamine. And this can be showing as early as 3 months after use up to sort of 15 years. So all about history and high index of suspicion. Next slide, please. Then we have some of our congenital conditions such as Crowley's disease. And again, this causes sort of cystic malformations in the intrahepatic ducts. And you can also see this on histological evaluation. Key things here is obviously the risk of cholangiocarcinoma. And if it's associated with congenital fibrosis, they also develop portal hypertension and need some supportive treatment there. Next slide. And also in the context of cystic fibrosis, we know that the cystic fibrosis gene also regulates the secretion of chloride and bicarbonate in the biliary epithelium. So similarly, you can get cholangiopathies. And again, it's another one that's often referred to us as a PSC before you get the underlying history. And there is maybe a role here for ursodeoxycholic acid, even though I haven't seen kind of great treatment reviews on this. You know, many patients will potentially be on that, and we may also be able to restore the protein in the context of the intestine, but many of these are managed in a sort of multidisciplinary context with the respiratory team and can indeed develop portal hypertension and secondary biliary cirrhosis in that context with an increased risk of cancer. Next slide, please. Obviously, the COVID cholangiopathy was pretty florid in and around COVID, both in terms of the intensive care unit, a bit like a critical illness cholangiopathy, but also post-recovery from COVID as well. And many did occur after recovery. So you would see when patients were really sick with COVID, you would continue to have biliary changes that you would see on MRCP. And this, again, could very much mimic patients who had primary sclerosing cholangitis, even though histologically it was very different, showing degenerative cholangiocyte lesions with lots of regenerative changes rather than the typical peribiliary portal fibrosis that we see. Next slide, please. And then, of course, you have IgG4-related cholangitis, which, to be fair, in sort of 80 to 90% of cases will occur alongside pancreatitis, which means you either see a sort of sausage-shaped swollen pancreas and or pancreatic atrophy. Again, predominantly in males, and you can see the demographics here, mostly older men around the age of 60, much more likely to have a higher IgG4 than in patients with PSC. And you can see in some patients, you have this sausage-shaped pancreas or this focal pancreatic mass, which can mimic patients who might have pancreatic cancer and biliary involvement. And you can see a homogeneous enhancement on EUS. And again, on ERCP there, you can see evidence of a distal stricture. Next slide, please. So in those patients, you'd often have an obstructive jaundice with weight loss, often get abdominal discomfort, but pancreatic insufficiency in the context of biliary disease is often seen both in terms of exocrine and also endocrine pancreatic insufficiency. So it's an important thing to think about when you think about the differential. Next slide. And in terms of cholangiographic findings, type 1 is the most common, so just a distal common bile duct stricture. So in an older male who often has an atopic history, when you've got a distal common bile duct stricture, plus or minus any pancreatic atrophy or pancreatic head involvement, you know, IgG4 is high up on your list in that context, and it does cause jaundice. And then the type 2 is slightly more PSC related. Type 3 is both intrahepatic and also biliary bile duct involvement, and type 4 being very much perihilar and the most difficult to distinguish from cholangiocarcinoma. Next slide, please. So just to show some typical imaging there that you see on ERCP, so you can see the distal biliary stricture, the hilar stricture that you see in type 4. Next slide. The role of cholangioscopy that obviously George has talked about, so I won't. And also, as you can see, the sort of PSC-like there. And as I say, main differentials across the board include cancer, as well as chronic pancreatitis, as well as primary causes of cholangiopathy. Next slide. The other things to say is if you have proximal disease, you're much more likely to relapse, and also you're much more likely to progress to cirrhosis. So even though we historically thought of benign disease being biliary disease in the distal area being very benign, we now know that proximal disease, this kind of PSC-like, is much more likely to progress to cirrhosis, and it's much more likely to actually have an increased risk of cancer. Next slide, please. And again, next slide. And I think it's really important in that context, not just to look at these patients in the HPB-MDT, but often you have to bring them out of the HPB-MDT and talk to other systemic disease specialists, particularly because this is often a systemic disease involving kidneys, salivary glands, and elsewhere. So this is the typical context where we think about a systemic disease involvement and also systemic MDT involvement overall. Next slide. In terms of treatment of IgG4-related disease, just a quick mention, steroids are really good. So there's an important role here for steroid trial if you think this is IgG4-related disease. And we usually give this for anywhere between 4 and 6 weeks and then image. And they need to be an appropriate dose steroid, so really 30 to 40 milligrams for that 3 to 4 week period in order to give sufficient steroids for the actual strictures to improve, which is what we would expect to see. Next slide. And I think it's really important not to misinterpret a steroid trial in this context, because patients do feel well from steroids. You can get a non-specific improvement of liver tests, and also pancreatitis can resolve if it's not due to autoimmune causes, irrespective of the underlying treatment. We also get false negatives in the context of fibrotic strictures, and also if you re-image too early. So you really need at least 6 weeks, I would say, in order to get a really good imaging evidence of response in this context. Next slide. Endoscopic therapy we've talked about, so I'm not going to cover that because George did, but just basically to say that you don't put a non-covered stent in. And in these patients, you can give them both immunosuppressive therapy and/or there's a good role for B-cell depletion in order to prevent the relapse of the disease. Next slide. And lastly, just to touch on PSC, because we can do that, and we'll probably just do that in one slide, actually, so that we have time for discussion. So PSC, as we mentioned before, is a condition which is immune-mediated and fibroinflammatory. And I think the key thing here is that it's really important to include those patients who have an inflammatory bowel disease. So the majority of patients will be young, potentially in their 30s. They're often male, and 80% of them will have an inflammatory bowel disease, particularly those patients who have an ulcerative colitis. So you're not looking just for intrahepatic and extrahepatic involvement here. And if you were to do a liver biopsy, which is not needed for diagnosis, but you might want to do it for small duct disease, you would see this periportal fibrosis, but also the presence of inflammatory bowel disease. And we can see P-ANCA positivity and also ANA positivity in these patients, but that is not a diagnostic test. And I think key things for me are the presence of biliary disease, the younger patients, and also the presence of inflammatory bowel disease, which often clinches the diagnosis. And rather than me talk about managing PSC, I'm going to stop in the interest of time so that we have an opportunity for discussion and questions.
Great, thank you. Thank you, Emma, and thank you, George. They were excellent talks full of lots of great information and tips as well. So we've got some questions here, so we'll just start at the top and slowly work our way through them, if that's okay. So I guess the first one's either for George or for Joshi. Can you tell us a bit about why you can't use the fully covered metal stents across the liver hilar?
As you say, either of us could address that. The reason, it's not an absolute, but it's nearly an absolute. And the reason is that if you put a fully covered stent, which has no side holes essentially across the liver hilum, then you will block drainage from the other side of the liver. Now, there are very rare scenarios in which we put bilateral fully covered metal stents across the liver hilum, but that's very, very small print. But actually, it might link in with a question a little bit further down from Wameda Taj Al-Din, which I see, which relates to the management of post-cholecystectomy strictures related to a surgical clip. And just a couple of words about that patients can get post-cholecystectomy strictures presenting clinically 20 years after the cholecystectomy. So it's always vital to really go back over the clinical history in a patient who presents with a new stricture. And we have on occasion used bilateral fully covered stents there to see if we can remodel the stricture, because that can be a really, really difficult scenario. There's no mechanism of going in and removing that surgical clip. And if you don't get effective remodeling of the stricture, then, you know, some of those patients need major surgery to deal with it. And it's important to remember that the stricture in that setting is often not just mechanical related to the clip, but actually is often ischemic. And that ischemic stricturing can extend proximally and be a real problem. So Joshie, you'll probably have, you know, lots of experience at King's of these nasty post-surgical strictures.
Yeah, and I think you're right, Georgia, a sort of a fully covered metal stent, being able to deploy that across the stricture and then coming back and reevaluating it. And you might have to leave the stent in for longer. And it's certainly sort of, you know, it's not just one session of stenting and can take a bit of time. Emma, I'm going to ask you a question. Somebody's written, any evidence of biologics in treating checkpoint inhibitor mediated cholangiopathy?
Yeah, it's good.
Like,
It's a really good question. I mean, obviously we use that in the context of immune checkpoint inhibitor colitis, and it seems to work quite nicely. And I've seen a couple of case reports, but I've not seen any list of good evidence to suggest that there's a reversibility. So in the same way that prednisolone doesn't seem to improve the strictures, I've not seen any good evidence that biologics, anti-TNFs or otherwise can do it either. So I did look at that before we actually came, because I've had no personal experience in using them. We've only used steroids and MMF, but yeah, it doesn't seem to prove to be a good role. There doesn't seem to be a good role for them in this context.
I think one of the issues we have sometimes, the cholangiopathy is picked up much later. So maybe that inflammatory component is already dissipated and you're left with fibrotic disease. So yeah, hitting them hard with steroids, MMF, or in theory, an anti-TNF agent is probably too late. I want to ask both of you, George and Emma, CA19-9, you sort of both mentioned it. Some people, you know, really rely heavily on it. What's your experience in your patient? How do you use it as a sort of, you know, descriptor of their disease, of the pathology? Do you use it at all?
Well, all I would say is that the people who rely heavily on it shouldn't, because in the presence of biliary obstruction, CA19.9 has no role. Full stop. We had a patient a few years ago with PSC and a dominant biliary stricture and a CA19-9 of 64,000. And when we relieved his biliary obstruction, his CA19.9 normalized. So, you know, I think in the setting, there's a tendency to say that everybody knows that CA19-9 goes up a bit in biliary obstruction, but if it's above 400 or if it's above 1,000, it's going to be cancer. That is simply not right. If the patient has no biliary obstruction, then, you know, it clearly is a much more useful tool. But, you know, otherwise, you know, we don't use it at all in the setting of acute biliary obstruction.
And I would agree with George completely on that, apart from the caveat of saying, I think in the context of PSC, when you first see your patient and you're doing your kind of complete set of screening and you have an intrahepatic cholangiopathy and you have a normal CA19-9, which is a later time point, potentially in the absence of a dominant stricture or with it, goes up massively, that's quite a telltale for us a lot of the time. And it's one of the reasons why we would push a little bit harder for investigating that biliary stricture. Again, the evidence for that obviously is not great, because there's not lots of details about the role of CA19-9 in predicting cholangiocarcinoma, as we well know, in patients who have PSC. But I guess it forms part of the total armamentarium when we're looking at our patients who have PSC. But outside of that context, I don't find it particularly useful, although I do find the serum IgG4 in the context of IgG4 cholangitis very useful.
Great, thank you. I think we've maybe got time for one more question. So there was a question for Emma. Do you manage autoimmune sclerosing cholangitis, so PSC with a raised IgG4 level, differently than just standard PSC, and especially when there's no response to steroids?
Yeah, I think that's so I suppose most of those patients who have a kind of autoimmune sclerosing cholangiopathy will often be what was called transition patients, so patients who are slightly younger, slightly more pediatric patients, and also patients who have what was characteristically called sort of PSC with overlap. So do I manage them with corticosteroids and immunosuppressants? Yes, I do tend to manage them with steroids and immunosuppressants, but it depends on what your end point is and your end goal is. And so it's not necessarily reversal of the underlying cholangiopathy. It will often be normalization of the ALT and or IgG and or evidence of interface inflammation in the context of a biopsy. So I think my end goal is very different. And we also know, a bit like what Joshi said before about biliary strictures being a bit too late for immunosuppressive therapy, sometimes in any kind of autoimmune cholangiopathy, we can see that actually there's a lot of fibrotic strictures, and therefore, unfortunately, these are not reversible with immunosuppression. And there's no point of plugging ahead with immunosuppression if there's nothing that's being reversed. So I think it's important to reevaluate after giving a 3 to 6 month time period and saying to yourself, am I actually achieving anything here, and what are my end goals?
Great. I just want to probably, well, we're going to wrap up this evening as webinar. So thank you, George. Thank you, Emma. Really great discussion. We almost feel like there's not enough time, but it's really kicked off the year in spectacular fashion and had some good discussion. So I want to thank our sponsors, Cook Medical. And yeah, we're going to be sort of following up with further webinars later on in the year. And certainly we can take up some of the discussion we've had today in further subsequent meetings. So thank you very much, everyone. Thank you for joining, and thank you, Louisa, for helping me co-chair today. Have a very good evening.